So my name is Agam Dewan. I'm a board certified psychiatrist. And in this video, we're going to be covering premenstrual dysphoric disorder, PMDD. And so with PMDD, what you have to understand, especially as a psychiatric provider, is it's like PMS, except more significant, and it is tied to the woman's menstrual cycle. So when you have a cycle, typically, let's say a 28-day cycle, you'll have the shedding of the uterine lining, and then you kind of have the building of the uterine lining. So this right here, so this is menstruation, and then over here, like the two weeks. So this will be about 2 weeks, and then you have 2 weeks here. And then this is the luteal phase. So ovulation happens right here when you have the egg, and then the egg will get sent off from the ovaries to lodge itself in the uterine lining, which is building up. So the uterine lining is building up here, and it will lodge itself right there. That's the whole idea behind the menstrual cycle. But when it doesn't lodge, right, and when there's no pregnancy that happens, then the menstruation happens and the uterine lining starts shedding, and then that's where bleeding and other symptoms occur. Now, for the PMS symptoms, the primary symptoms occur here in the luteal phase. So usually about 1 to 2 weeks out, that's when they occur. So it's symptoms of depression, irritability, anxiety, and these affect the function. Basically, it's a more severe version of PMS. So this is a common complaint that many women have. Okay, how do we address this as providers? So the first thing we got to do is we got to make sure it's actually the correct diagnosis. So one, I'll say confirm diagnosis. So the way you do that is you have a symptom diary where the patient will correlate what their symptoms are in relation to their menstrual cycle. So at least over 2 months, they can see that, okay, this is actually correlated to their menstrual cycle and not something else. And just having that gives people a lot of clarity. Okay, now let's say that we have confirmed the diagnosis and this. What's that? The mainstay treatment for PMDD is SSRIs, but there's actually two methods of doing it. So one is what you call luteal-phase dosing. So with luteal-phase dosing, you would give the SSRI only during this phase. And so they wouldn't take it during this phase, and then so they would take it during this phase. Two common ones that I've used have been Lexapro and Prozac. Lexapro just tend to be well tolerated, and Prozac is used. I like Prozac because it has very little withdrawal. So you can give it during the luteal phase and then not during the menstruation phase, and then they're not going to experience much withdrawal as they don't take it for 2 weeks. So that's the one way to dose it. But then you can also do or continuous. So then there's just straight up continuous phase dosing where they'll just take it all around. That's definitely the easier one to do. So if the patient is having symptoms that are breakthrough, like let's say they're still having some symptoms during the menstruation period, it might honestly just be easier to diagnose or to give it full term. But if they're having luteal phase issues primarily, then you could just do it during that time. But you can also do a hybrid approach where the patient takes a lower dose during the menstruation phase and then a higher dose during the luteal phase. For example, I have this patient on Lexapro, and so she takes 10 milligrams during the luteal phase and 5 milligrams during the menstruation phase, and she does well. So that is what works for a lot of people. But let's say that doesn't work, then this is where it will get out of our hands. You can go to OCPs or hormonal. So this is something that typically an OB-GYN would do. But then they'll be able to do like estrogen-based treatments, oral contraceptives to help regulate the cycle. So those have been shown to be helpful too. And that's when it will get out of our hands. But number 4, so I'll add on something that we can at least do are supplements. Let's say we would go from 1 to 2 to 4. This is another prescription option, but supplements. So supplements wise, there's 2 that are really helpful. Actually, there's three. So calcium carbonate. Calcium has been shown to be helpful for some of these symptoms. Chasteberry extract and magnesium glycinate. So calcium carbonate, you can do 1200 milligrams. Chasteberry, it kind of varies from extract to extract, but basically just getting them into the system, that's the most important thing for the chasteberry. And then the magnesium glycinate, I like 200 to 600 milligrams, depending on the patient. So yeah, these are supplements we can definitely introduce, but the mainstay are SSRIs, and then confirming the diagnosis. So that's pretty much it in a nutshell, what you need to understand about PMDD, its diagnosis, and its treatment. And so if you want to learn how to really address psychiatric problems, especially with real life patients in more detail, best way to do that is in our coaching program. So for example, our NP students will they'll ask me about, okay, how to treat PMDD, and then I'll give my answer and how I've done it in practice, but then also the theory behind it as well too. So this is the kind of thing that we discuss regularly. So if you're struggling with clinical confidence, understanding the nuances of psychiatric treatment, and you're looking for more real world psych guidance, best ways to do that is in our coaching program, where we had over 200 students sign up and go through so far. So I hope that this has been helpful, and I'll see you in the next video.